So without further ado, I want to introduce Sherri and Robert. And Sherri and Robert are going to be talking to us today about Westernized approaches to caregiving. So I think we're ready to go ahead. So Sherri and Robert, you can take it away.
So I'm just Sherri Henderson. I'm a registered nurse that works at with the Northwest Regional Program, and I do the telemedicine consultant for the Northwest region, and I answer the 24/7 line. And good evening. Looking forward to tonight.
And my name is Robert Essex, also a registered nurse. I work for Thunder Bay Regional Health Sciences Center. I am the inpatient palliative care nurse that works there. And I think the presentation we decided, I'm going to do the first little bit, and then I think Sherri's going to do the second half of it. So I've done a lot of one-on-one teaching in my career, but certainly not talking to a group quite this large. So all it is, if I'm nervous, I'm going to try really hard not to just read the slides, but actually offer information and talk about palliative care, sort of the Westernized approaches to what we do. So we can go to the next slide. Oh, and this is me again. I work for Thunder Bay Regional. This is sort of my disclosure slide. Really, most of what I do is just go to work, and they have lots for me to do there. Tonight, I am getting an honorarium for doing this tonight. And then the next slide.
So again, this is just me. I work for St. Joseph's Care Group, like I said, and I've done some facilitating with the Lakehead University and with Pallium Canada. And I've had a pleasure to always work with Holly, which is fabulous. Good evening. And I am too getting an honorarium for this evening.
Okay, so this is our learning objectives for the night, or for our conversation. And really it is just to talk about Western approaches to palliative care, pain and symptom management. And we're talking to two nurses who work in healthcare, so it's really through that medical cultural lens. We'll go to the next slide. And this is some definitions of what palliative care is. I think, we'll see a lot of the same language kind of get repeated over and over again. Palliative care really is caring for people who have life-limiting illnesses, life-threatening illnesses, for a variety of reasons, but certainly isn't restricted by age, should not be restricted by location, lifestyle, culture, all those kind of things. Yeah, and I think it mentions our focus or involvement might change based on where you're at, but I think we have a really good slide coming up that talks a little more about that. We can go on to the next one. This is the title slide. So yeah, one more please. Okay, so this again talks about more of the same kind of stuff. It's sort of looking at the whole person. So palliative care, so Western medicine, I think, looks at, often it's, we associate going to the hospital, going to see your doctor. It's very location or sort of focused on clinics and hospitals. But in palliative care, I think we really do try and look at holistic, the whole person. We try and look at the physical, psychological, social, all aspects of a person, and try and treat the whole person rather than just the medicine. I think the literature talks about a couple different things. One is palliative medicine, which is really the management of patients with medications, focus on care, quality of life. It's more physician oriented. And I think palliative care is a broader term that incorporates the whole team, the whole person. Is looking at many dimensions of that person and what quality of life or what care is to that person, and trying to meet those needs. Yeah, I think that sums it up pretty well. Let's go to the next slide. Okay. And Kevin probably recognized this because I stole it right from his presentation, but also gave credit to where it's from. But I think this is a really good overview of sort of what palliative care is. I think a lot of people associate palliative care more with terminal care. And I know we in palliative care probably spend a lot of time trying to refocus those thoughts, or trying to reassure people that, you know, we don't just do terminal care. We certainly look at people along their trajectory of illness. We do a lot of terminal care, a lot of end-of-life care, but we also do a lot of other things, which you can see there. Yeah, I mean, we can probably talk for a long time about any one of those topics, but you can see it's more than just the medicine, more than just the treating the symptoms. It's really, you know, investigating the person and, you know, treating them spiritually, medically, symptom-wise, treating their families, all those kind of things, and incorporating what makes sense to that person at that time, right? So, you know, yeah, I think that kind of sums up what I was trying to say there. Yeah, thank you. And palliative care is done in a variety of settings. So hospital is at the top there, not because it's the most important, but it's where I work and probably what came to mind first for me. But really, it's one of many settings that palliative care can take place. You know, it's not the only place. Obviously, we look at for people really wherever they are. You know, in acute care, when acute care needs are required, you know, for acute symptom management, we do in the hospital a lot of clarifying goals of care and really investigating who that person is and what different treatments mean to them, or you know, trying to clarify whether the burden of a particular treatment really is going to give them the quality or quantity of life that is meaningful to them. And I think in hospital, I think we often focus on, you know, the medical model, especially in acute care, is you come there, we treat you, we give you all kinds of options, and we kind of do stuff without slowing down and thinking, you know, is this the right thing for this person at this time? And I think that really is one of the advantages of palliative care, is that, you know, we try our best to slow things down. We definitely you know, I think the medical model often is in the hospital anyway is very quick. It's very short interactions. It's not a lot of depth often. Where in palliative care, I think we really do make an effort to come in, find out who you are. You know, we sit down, we talk to your family, we talk to you, and that way we can carry on what you want or need at that time. But we can do that in the hospital, but then carry it on to the other locations, whether you're at home or in remote communities or wherever people are, is the last thought I put in there. And really trying to, you know, look at people not through the lens of who we are or what we value, but what they value, who they are as a person, as a culture, as a subculture, as all those things that are meaningful to them and their families. And one of the biggest lessons I learned in the last year was really working with some of the homeless clients and recognizing that, you know, just because I think everybody should live in a home and be cared for, it doesn't mean that everybody thinks that way. And for some people, home is not in, you know, a walled house, but is with their friends and family, whether it's on the streets or in shelters, or it's the place they want to be, and then trying to figure out how to meet those needs in those places. So really, I think the whole palliative care team in Thunder Bay does a really good job in trying to meet the needs of the patients and the places they want to be. And it is a struggle to try and reframe, you know, a system that's based on, you know, the Western medical model, trying to, you know, say, you know, it's okay to do things differently for different people because that's what they need. Yeah, and I think there's a lot more we can do, and we'll keep trying to do, but I think we do strive to do the best we can for the people that we look after. Okay, let's go to the next slide. And this is the interdisciplinary team, just kind of summing up some of this, which most of us probably know, but it really is, it's looking at supports in all aspects of life. You know, it's not just the physicians or it's not just the nurses. It's everybody's part of it. The family's part of it, you know, social workers, spiritual care, and really all the other disciplines that somebody might need, and certainly being able to access those resources and trying to get those resources to provide supports for wherever that patient is or wants to be is what we try and do. And that way we can, you know, no one person in healthcare can meet all the needs of one patient. And I think we really do work as a team to try and do the best we can to meet that patient's needs at that time. Yeah, that might be my last one. I think one of the most important parts, I know I'm running short and Sherri's up next, but one of the most important parts of our job really is communication. It really is sitting down, is looking like you want to be there, sitting with the patient and talking to them and trying to find out what makes sense for them and what's going to help them the best. And I think that's one thing we do really well in palliative care. And I think that's one thing that kind of sets us apart from a lot of other Westernized medicines, is that we need to take that time. And I think we can head on to the next slide. And this will be Sherri.
Thank you, Robert. That was a really good summarize of what palliative approach to care is. So I'm going to move on to the pain and symptom management. So the next slide, please. So just a definition of pain, and we know that pain is subjective, and it's what they define and what their unpleasant sensory or emotional experience. So it is coming from the person that expresses their pain, and it's also influenced by their past experiences. And this next slide. So Cecilia Saunders, she came with the term of total pain, and that concept of that is suffering, and it's total suffering, and it encompasses the person's physical and psychological and social and spiritual and the practical struggles that someone experiences with pain. So when we look at pain, especially with a palliative approach to that care, it is to look at that whole aspect of what pain is to them. So next slide. So when we do this, this is the assessment tools we use. We can do the Memory Rating Scale. There's the acronym of just doing a really good pain assessment. So you want to know, like, what is the onset, provoking, like what's causing, the location of the pain, and description of the pain. So you really want to get a good understanding of what that is for that person, so that we can really address all, giving a good pain management. So again, just really getting, and so when I do my consulting and I get calls from the Northwest regions, and people will be calling about pain, I will be asking these kind of questions, and what makes it worse, what helps, and also when I'm at the bedside, what pain medications have worked in the past, what has been helpful in the past, what makes it, like what provokes it. Is it worse in the evening? Is it incident pain? So when they do any activity, is it worse? So you just really want to get a good understanding of that, so we can really address that. And then again, if they're not able to express it, because I said, then again and again, geriatric floor dementia, we will also look at that like nonverbal, so the Flaccid scale. I'll use that. And then for other symptoms, again, I'll use the Edmonton assessment system, which I'm sure a lot are familiar with. So the ESAS. So again, just getting really, it's 9 symptoms that we address, plus there's an option for another. So, and it is really important that it be the person that answers that question, because again, these are subjective symptoms. So I find if nurses were to answer this, usually those numbers will be skewed, and they'll be lower. And again, if families answering it, they'll tend to maybe increase those numbers. So it's really important for it to be a valid tool, that it comes from the person, and it's about what they're feeling at that time. I find it is just a good assessment again of which is going on in this person, to try and focus more on that quality of life, because that's what we're trying to do in palliative care, is address those symptoms and make the best quality for that person. And then just the types of pain, we'll go through that. And the acute, and just again getting a really good assessment so that we can provide that pain management. And so on to the next slide. So again, the pain management, we're going to look at that pharmacological medications and also the non-pharmacological. So again, it depending, how if it's mild, moderate, or quite severe, then we'll be starting with mild would be the the non-opioids like Tylenol, Advil, sort of using those medications. And then again, as we go into the opioid medications, if it's more moderate to severe. And again, just with, even when the pain management, you also want to do a lot of education, because there's a lot of stigma around opioids and opioids use, and you just want to address that and help the client and the family understand the use, and also do a good communication about the adverse effects. Again, sort of those stereotypes and myths. I find people say, again, worried about addiction, think they have, and those adverse side effects to the pain medication, they think that's allergies, and they're actually just, this is what opiates side effects cause. And some of those are very, those adverse, reactions are not pleasant. So again, we have just that, and we'll have medications that would be used along with the opioids, and then just the adjunctive medication. So there's lots of approaches, and again, you would start slow and then titrate till we get to that tolerating of addressing those symptoms of the pain. We can also use other things, which is not, again, we use examples there, radiation, nerve block. So those are different just approaches to help with the treatments. And then the non-pharmacological approach. So again, just repositioning, cooling, and asking what's worked before, like and what does work and what doesn't. So, I find also when they're in the pain situation and it takes, if it's peripheral, then it will be, the medication will work very quickly if it's sub-Q or versus oral. So again, what else can we do to manage that pain if it is, quite disconcerting for the person? So this is sort of a good palliative, a good, good symptom management approach, and also just that good communication and evaluation afterwards. Is it working? And what can we do if it's not? So then this is the next slide. So again, just some of the symptoms that people can experience with palliative care. So again, nausea and vomiting. That could be also from whatever the disease process or treatments they're receiving, if they're doing chemotherapy, like palliative chemotherapy along, or is it because of the opiates that we've started, because that's nausea is quite common. And then also just, again, if you're on opioids, and just really addressing those bowels and constipation. Fatigue factor, again, fatigue is very distressing. So these are just some of the symptoms that can possibly arise. And then they can also, with confusion, it could be disease process, it could be infection. So you also just doing a lot of assessing and evaluating and what's going on with this person to, again, be focusing on the best quality of life for them and what that means to them. And you see dyspnea, difficulty breathing, anxiety. I find those, there's sort of a positive correlation. Is it the anxiety that causes the dyspnea, or is it the dyspnea that's causing the anxiety? So again, just that, and good assessment. myoclonus, and you have to watch for, again, toxicity of opioid. We can maybe be doing scheduled medications of opioid and also as needed. So sometimes we have to just make sure that it is being properly managed and titrated, and they need to rotate. So this is just it's a lot on that slide. There's a lot, again, like Robert said, we could spend a lot of time. We're just doing sort of a brief overlook of how we address symptoms. And then on to the next slide. And then again, with that total pain, you actually went one too fast there, Stephanie, back one. Just again, that emotional and spiritual suffering. Again, with that total pain, the anger, frustration, and like Robert mentioned earlier, it's a lot of communication, and communication, the key to communication is listening. So it is at that bedside and listening, or if they're in their home, and it's just really getting that and letting them express this and acknowledging this frustration, and even naming their anger and naming it and being just present. And then that, loss and the meaning, and questioning, religious beliefs, and that's, it's just important for them to express it. And again, that really much that team approach is really important when we deal with this sort of overall suffering and total pain that people feel, and that burden. I commonly hear burden, and that feeling of burden on others, and those losses. And helplessness, hope, loss of hope, and hope shifts. So we always have to remember that we don't take hope away in palliative care, but hope changes. And so again, just those conversations and listening, and lots of listening and being present. On to the next slide. So again, that's good symptom management with the different types of symptoms. So again, opioids we'll use for dyspnea, inhalers, oxygen, positioning, we'll be raising them up if they're having difficulty breathing. You sort of help the pillows, positioning, and again, just other examples of medications that we would use for nausea. What's causing it. And nausea, again, is another one. You think of pain and we ask when it onset. Again, it's quite complex. So there's a lot of questions as when and why, when's it happening, when's it, is it when you just smell food, is, what is causing this? And again, what treatments are they receiving, and how we can address that. So again, lots and lots of just sort of getting to really get down to understanding what is happening in this patient's life. And again, that non-pharmacal approach. So again, with dyspnea, again, like elevating, opening the window, just helping with that breathing techniques. And again, being present. I can remember one time a man he had COPD and was really struggling. And he got really into that anxiety and panic attack, and not feeling like he can breathe. And when you can't breathe, nothing else matters. And he was just in our outpatient clinic, and he was waiting for the cab, and he just started to really have that panic. And I just stayed with him, and I said, and I just, I put he was in the wheelchair, and I just put my hand on his shoulder. I said, I'm a nurse, and I'm here, and I'm not leaving you. And I just stayed with him, and I said, I'm here. And I just helped him with his anxiety and his breathing, and he calmed down. And he always said to me, that was just made the difference of just letting you know that I was present and I was not going to leave him. And then again, just using that interdisciplinary team, like we use all that approach that Robert spoke about, because that is just, it is a very much team approach for all these complexities of symptoms that we try to manage. And it does really take a team. And I do feel that the palliative team does really utilize all the resources that are there. So I think the next slide is, so again, just like Robert had said earlier, palliative care is very much active care. So it is very focused on, and that the quality of life, and listening to that patient, and having a plan that is very patient and family-centered care, and providing lots of support. So any questions?
Miigwech, Sherri, and Robert. So we're going to have a couple of minutes here. If people have questions for Sherri and Robert about anything that they talked about, or anything that you would like them to further elaborate on. So anyone questions? And please, Elton, let me know if I missed anything in the chat.
I have a quick question, and I'm not sure, it might be a silly question. But with palliative care, is it ever used in scenarios where somebody doesn't just have like an elevation or in quality of life or length of life, but actually recovers from the thing that led them into palliative care?
So Sherri or Robert, Risa, it was a question brought forward by Risa.
So I understand your question is you're saying if they came into the palliative care for like a referral or services and then didn't need them further on afterwards, so more like a symptom management approach and not end of life, is that what you mean?
Yes.
Yeah, we have we have done definitely that sort of pain and symptom management, because sometimes in and again other areas will tap on the resources and the knowledge of the palliative team for that good symptom management. And I sometimes feel it too. I get referrals for chronic pain. For his chronic pain, we don't really address as much. We will tend to, again, if they are asking for that chronic pain sort of service, I will direct them and connect them with the chronic pain team at St. Joseph Care Group Hospital.
Miigwech, Sherri. Did you want to add anything, Robert?
No, I think that was really well said. Yeah, and I think my experience kind of reflects the same. I think we tend to focus more on life-limiting illnesses, but again, if we don't know what's going to happen, right? Sometimes we get involved, and then as things settled, we might back up a little bit. But we also couldn't see every patient who comes, through healthcare too, right? So, yeah.
Miigwech. And Jill shared a tool in the chat, and this was a tool that was created by the Indigenous Patient Navigator at the Thunder Bay Cancer Center as a good tool for communication with some Indigenous clients. So again, these are tools that we can share following as well. But again, take a look at that. Anybody else have any other questions? So if there's no further questions, I just want to acknowledge that Elder Jerry does have to leave us. He's not feeling so well at the moment, so he sent me a message saying that he was going to leave. So miigwech, Elder Jerry, and I hope you do feel better. So we set the stage tonight for this discussion from a Westernized approach of what palliative care was. And one of the things that I often reflect on as an Indigenous person working with those preparing for the journey is the synergies that exist between palliative care with Indigenous ways of knowing around caregiving, and the synergies that exist between recognizing that it's not just the individual, it's also the family as well and the community. And it is the holistic focus. So these are some of those themes that we'll carry on in the next couple of weeks as well.